This is our 8th or ninth annual fall webinar, and I'm so glad that you could be here. We have a number of great questions that have come in, and we'll spend the next 2 hours or so reviewing some of these wonderful questions. This will be recorded and this will be posted to our Donovan Medical YouTube channel, and this will be accessible at a later date for you. We may not be able to get to all of the questions that have come in because there were so many, but some of them were overlapping, and so I have condensed them into common themes. And we'll be talking about hair shedding disorders. We'll be talking about questions related to androgenetic alopecia in both men and women. We'll be talking about alopecia areata, scarring alopecia, and some other very interesting questions. So once again, I thank everyone for sending in such terrific questions. As we go about talking about these questions, I want to remind you, as I do every year, that hair loss is a pretty complex subject. At first glance, it seems pretty simple and straightforward, but it can be actually quite tricky sometimes, and there can be mimickers, and there can be some overlapping conditions. And so the proper diagnosis of hair loss really requires a full history. I need to know what's happened to you at age 5 and 10 and 18 and 23. We need to evaluate your scalp, including trichoscopy with special microscopy. Sometimes blood work is important, as we'll see today in a couple of cases and questions. Sometimes we need to do a biopsy. And so we always need a story and an examination. Those things are always needed. And every day we have so many emails that come in with photos and trichoscopy photos. What do you think of this, Dr. Donovan? What do you think my diagnosis is? Without a story, we really can't answer that with great certainty. And so what happened to you at age 5, 10, 15 absolutely matters to your hair now at 43 or 55. Absolutely. And so the story always matters, the examination always matters, and this theme will resonate several times today. And so just as a reminder, our webinar today is for educational purposes. And if you have hair loss, you really want to make sure you see a professional. The other thing I want to remind you about is we will be talking about many treatments today. Lots of great questions have come in about topical finasteride and treatments for scarring alopecia. Many of the treatments we'll talk about are what we call off-label. The only things that are FDA approved are minoxidil topical for women and men, finasteride for men, and some of the JAK inhibitors for advanced alopecia areata. But everything else is off-label. And in the clinic, each and every day, we have over 100 treatments that we use for treating hair loss. And these are off-label. And so just as a reminder, I probably won't repeat myself over and over that this is off-label and that is off-label, but please remember that. So this is how we diagnose hair loss. And so when you say to me, I want to ask you something about my hair. I started shedding last week and I've changed my diet. And what do you think's going on? You can see when you look at this slide that I can't tell you what's going on, because to diagnose hair loss, I first need a story. Tell me about your life. Any issues in your medical history in childhood? What's your family history like? What do you eat? Have you had weight loss? Do you have itching, burning, or pain or shedding? Tell me the story. Then I have to examine your scalp, looking for signs of scarring versus non-scarring alopecia, other inflammatory disorders. And then sometimes I may need blood tests. Sometimes I may need biopsies. Sometimes I may need special tests like hair collections, swabs for bacteria, swabs for viruses, electron microscopy of hair shafts. And then once I put all this together, I can get a diagnosis. And so a passing comment, I got to ask you about my hair. What do you think? What's the diagnosis? Sometimes I cannot say because I do not have enough information. And so this is a very simple template on this slide of how we diagnose hair loss, but these steps must never be omitted. So let's start with our first question. So I've grouped these in a couple of themes, and we're going to start with shedding disorders. One of the most common causes of shedding that we think about in the general public is something called telogen effluvium. Telogen effluvium is a hair shedding disorder that happens after stress, low iron, thyroid problems, medications, diets, weight loss. It usually happens a few months after your body experiences these triggers. You get COVID-19 in July, and you shed in September. You go on a diet, a month later, you start shedding. You had a stressful event in April, and now you're shedding in June. Telogen effluvium is a hair shedding disorder that starts about 2 or 3 months, sometimes 6 weeks, after some kind of a trigger. And so our first question is a complex question, but a wonderful question. I have had extreme scalp itching and shedding off and on for 20 years. My hair has thinned a lot. This shedding happens at certain times of the year. I originally went to 9 different dermatologists without really getting help. What do you suggest? So thanks so much for this great question. There's several really important points in this question. There's a story here of itching. There's a story here of shedding, progressive hair loss, and a seasonal change. So it's possible we have one diagnosis that's explained by all 4 of these things, or maybe we have 4 diagnoses. One that causes itching, one that causes hair loss, one that causes shedding, one that causes seasonal changes. Or maybe we have 2, and some of these overlap both of these conditions. But we have to think about all of these pieces of information that have come in this question. Now, as you can see in our first slides to today's webinar, to diagnose hair loss, I need a story, a detailed story. Yes, there's been itching and shedding for 20 years, but what happened the 10 years before that, 15 years before that, 20 years before that? What's the family history? What's happening to the eyebrows and eyelashes and the skin and the bowel and the heart and the lungs? What other medications are taken? Who lives in the house? Any pets? Where do you travel? How often do you travel? You can see that every piece of information in a history really matters. Why in the world, Dr. Donovan, would travel history matter? Well, seasonal ultraviolet related shedding can happen in many people that travel from sunny climates to less sunny climates and back. There are different infections in different parts of the world that you may not have been exposed to and you get exposed to. We don't have dengue virus here in Whistler, Canada. But if I travel to somewhere with dengue virus, then it's a definite etiology of hair loss. So you can see that everything matters. Every piece of the story matters. And so we've got these 4 things to consider. What causes itching? Well, lots of things cause itching. Here's a short list of things that cause itching: dandruff or seborrheic dermatitis, psoriasis, telogen effluvium. When you start shedding, you get itching. Scalp dysesthesias, where you have nerve-related itching in the scalp. Stress can cause itching. Alopecia areata, infections. What kind of infections? Every infection can cause itching. It's the way your body says, hello, help me. You get itching. Scarring alopecias, contact dermatitis, some kind of allergy or irritant. and then autoimmune diseases. What a long list of things that cause itching. What causes shedding? Similar list, isn't it? Few differences, but a lot of those things that cause itching can cause shedding. What causes hair loss in general in a progressive nature like described in this question? Well, lots of things, and the list is pretty similar. And then what conditions are seasonal? Well, many of us are now familiar with seasonal shedding, where so many human beings shed in the fall. This is the peak time of the year where people shed. Some people shed in the spring. But there's other seasonal things that a hair specialist needs to know about. Seborrheic dermatitis is seasonal. We're coming into winter here in North America. That's when seborrheic dermatitis often gets worse. Psoriasis, alopecia areata, they have a seasonal nature. Some infections do. There can be a seasonal nature to other issues like atopic dermatitis. Scarring alopecia sometimes when they're triggered by ultraviolet radiation. And there are some issues that are called photodermatoses where the sun influences eruptions on the skin. And so when someone says, I have hair loss, it's seasonal, it's itchy, I have to think about all four of these things at the same time and think about, does this person have one condition that explains everything or four conditions, each explaining one of these? And so with this particular question, it's hard to know because I don't have enough information. But what is the most likely situation in someone that says, I've had hair loss for years and years and years. It comes in seasonal sometimes. It changes with seasons. And it's itchy. Well, the most likely causes are androgenetic alopecia with some amount of chronic or acute telogen effluvium, with a background of seborrheic dermatitis or psoriasis, and possibly a contact dermatitis. These are statistically the most likely things with a story like this. Could it be something else? Absolutely. We don't have enough information. But statistically speaking, these are the issues. So what would I need in a situation like this for my own patient? Well, I need a really good history. What do you mean by seasonal? What season? Does it only occur in September, or can it sometimes occur in May? And if it only occurs in September, where are you in September? What are you doing in September? Why September? We need to do a really good examination. There's no substitute for an up-close trichoscopic exam. There's nothing that substitutes for that. Sometimes we need lab tests. Certainly in anyone with shedding, we need thyroid tests, iron tests, but sometimes we need other tests as well. And there's a whole list of about 82 tests that are on my blood requisition form. Do I ever order some of those 82 tests at the bottom? Absolutely. Just not in everybody. Most people, I only order 4 tests or 5 tests. But throughout a given month, I'm ticking off most of those boxes at some point. But it depends on the story. And so the blood tests we order entirely depends on the story. And if there's a suspicion here that there's an allergy, maybe a contact dermatitis that the person is coming into contact with, then sometimes we do a special test called patch testing, where we try to determine what allergy someone is experiencing. You know, every summer I go off to the cottage and I come back in September and I'm shedding. What's in that cottage that you're being exposed to? That's why history is so important. And so the way we treat this will depend entirely on the diagnosis. And that's a really important principle in hair loss, that the way we treat hair loss depends on the diagnosis. And so there are no generic treatments for hair loss. We specify treatments based on the diagnosis. And so in order to help this individual who sends in question 1, we need a diagnosis. But really a wonderful question that allows us to think about a number of things in parallel. And I thank you very much for sending in that question. And as we continue here, if you have questions in addition, please put them in the chat box. And should we have time at the end, we will answer them. Every year we manage to usually get through about 25 questions, 20 to 25. And I hope to do so this year. Let's take a look at question number 2. Question number 2 is from an individual who emails us saying, I am a 38-year-old female with hair loss since age 34. I have received a diagnosis of telogen effluvium from low iron and low vitamin D. What do you suggest as far as doses go for correcting these issues? How long will it take to get my hair back? This is such a great question and such a common question. And there are several issues when I hear this question, which is one of the most common questions we get every single day in the clinic. We have a 38-year-old female with 4 years of hair loss. She's been told it's telogen effluvium. Pretty unusual for telogen effluvium to go on 4 years. In the mind of the public, the general public, it doesn't sound so strange because a large number of people think they have telogen effluvium when they don't. Telogen effluvium is a hair shedding disorder that happens from low iron and low vitamin D sometimes, thyroid problems, as we mentioned. But usually it's a problem that lasts a year, 6 months, 4 months, 8 months. When you have telogen effluvium as a diagnosis that's been going on for 4 years, the number one issue in my mind by far is that androgenetic alopecia is here, female pattern hair loss. And that is a really important principle that we teach doctors. That if you have a patient with shedding for many years, you have to give up the diagnosis of shedding as number one and consider androgenetic alopecia as number one. There may be telogen effluvium, but the most likely is androgenetic alopecia. And so this patient in this question is saying, I got telogen effluvium, my iron is low, my vitamin D is low. How much of the iron should I take, Dr. Donovan? How much vitamin D? Well, first of all, I'm not so certain you have telogen effluvium. Of course, I would need a story. I would need to examine your scalp, and I would need to see these lab tests in order to give a diagnosis. Ferritin or iron has to be pretty low to give shedding. Ferritin's in the 30s and 40s. They are not always responsible for shedding. Many people see their ferritin as 32 and 41 and they feel, aha, this is the reason for my hair loss. It's not. In most cases, it's not. When ferritin gets 21, 19, 18, 13, 12, wow, then it's likely a cause. But not at 32 and 38. It's rarely a cause. And so I don't know the ferritin in this question because it hasn't been sent in, the ferritin value. But if it's above 30, it's not the cause of hair loss for 4 years. Same with low vitamin D. Vitamin D has to be pretty low to give shedding. The cutoffs for normal and hypovitaminosis D or low vitamin D are pretty generous in the population. And so if your vitamin D is a little bit low, it does not necessarily mean that it is the reason for shedding. But certainly if vitamin D is low or iron is low and it's thought to be implicated, then we take iron. And there's no standard dosing in my mind. If your vitamin D is very, very, very low, well, then you need a good dose. If your vitamin D is just a little bit low, and we just want to be cautious and give you a little bit, then we give you 1,000 units a day or 2,000 IU per day. But if your vitamin D is quite low, you might take 3,000, 4,000, 5,000. You might take other forms of vitamin D, which allow you to be dosed once a week. Same with iron. If your iron is just a little bit low and we just want to cover our bases and give you iron, we might use iron once a day. If your iron is really, really low and you're anemic and you're short of breath and you can't go upstairs and your conjunctiva in your eyes are pale, well, then you might take iron 3 times a day. So the dosing depends on how low it is. But this is such an important question that has been sent in here, and that is many people who think they have telogen effluvium may not have telogen effluvium, especially if it's been going on for more than 3 years, 4 years. And so when someone says, I've had telogen effluvium for 4 years, my feeling is, this is strange. Something might not be right here. But of course, I need a full story. I need to examine the scalp, and I need to look at these tests myself. But thank you so much for that wonderful question. That is such an important question that not only stumps patients, but stumps doctors. And that is absolutely critical. So I'm glad we had a chance to review that. Now we're going to move into androgenetic alopecia, and we've had a number of questions, maybe 10, that have been sent in regarding androgenetic alopecia. And so I really appreciate this opportunity to talk about androgenetic alopecia, which is one of the most common causes of hair loss. 40% of women in their lifetime will get androgenetic alopecia, 80% of men. It looks different in women and men. On the left, we have female pattern hair loss, female androgenetic alopecia, where we have hair loss in the middle of the scalp. Here we have male balding with hair loss in the crown and the temples. When you look up close, the hairs are getting skinnier, thinner. We call that miniaturization. So they look different in men and women, but it's a similar process. And so let's take a look at our first question related to androgenetic alopecia. I would like to know what the average hair length gain is from taking oral minoxidil. So we treat androgenetic alopecia with topical minoxidil, oral minoxidil, anti-androgens, laser. We'll talk about the treatments in just a minute. But oral minoxidil has emerged as a popular option for both men and women. And this individual asks, what is the average hair length gain from oral minoxidil? The reason this question comes in is because the one thing that women notice with androgenetic alopecia is not only are they getting thinner, but they can't grow their hair long. They used to be able to grow their hair down past their shoulders. Now they can't grow it long. That's a classic sign of androgenetic alopecia, because what happens in androgenetic alopecia is not only do the hairs get skinnier, but the hair cycle is affected, such that hairs don't spend as long in the growing phase, and so they can't grow as long. And so this individual is saying, I can't grow my hair as long anymore, and I want to know how much improvement can I expect with oral minoxidil. So we don't evaluate the success of treatment based on hair length. That is not how we evaluate improvement. But in general, let me say that if a treatment is successful in androgenetic alopecia, it is likely you'll be able to grow somewhat longer hair because the hair cycle improves somewhat. But when we talk about the success of treatment, and when we do research in androgenetic alopecia, we do not use hair length as a parameter. When we want to know how well a treatment works, we measure hair counts. How many more hairs do we get? If you take oral minoxidil every day, 6 months later, how many more hairs do you get? If you take oral minoxidil for 6 months, how much fatter do the hairs get? And if you take oral minoxidil for 6 months and you have 100 people doing so, what percent of people feel they're better? Those are the parameters we use. So when you look at research studies, these are the parameters we see. We don't see the hair length improved 1/2 inch or the hair length improved 2 inches. That will happen in many cases, but not always. Sometimes people will get an improvement in their density. It's less see-through. They feel like they have more volume. They feel when they go in a bright elevator under the bright lights that they feel more confident. But yet when you ask them, are you able to grow longer hair? They may say, not really. So they've had a successful treatment, but some of these people haven't experienced that improvement in length. Some do, of course, but we don't use hair length as a key parameter. And so that's important to remember. And so when you ask your hair specialist, what's the improvement in hair length I can expect? You'll probably see a blank stare because this is not a parameter that we talk about in the hair world. We do not have a statistic that we can throw out. Whereas we can say that 40% of women on oral minoxidil experience, women using oral minoxidil experience a 40% improvement in hair density. 40% of women on oral minoxidil experience an improvement in density, 20% very significant. So these are the statistics that we're able to quote very readily, but not hair length. So thanks for that question. Really nice question because it allows us to reflect on those changes in hair length. And some women are very bothered by the inability to grow longer hair. Now, men, because they wear their hair short a lot more than women, are less bothered by the change in the hair cycle. But some women will notice that the only way they can get the hair to look straight across the back is to cut the hair shorter and shorter and shorter over time. Question 4. How do you decide whether to place a female with androgenetic alopecia on spironolactone or oral minoxidil? Great question. And there's a little bit of practitioner preference in thinking about this question, but I'll show you my views. And we've published this in an article which is free online in Cutis 2024, January, and you just type in androgenetic alopecia, what works, and up pops this article. These are my algorithms for premenopausal women and postmenopausal women. And you can see, first of all, that, wow, there's a lot of words on this slide. And that's right, because there's a lot of potential treatments for female hair loss. But we categorize these into first line, second line, and third line. And the purple box is things that they're a little bit interesting to me, but it's unclear the interest really. Large, randomized, good studies have not been done. There may be anecdotal reports of benefits. They may be popular, but good quality studies have really not been done. So first line, second line, and third line treatments are treatments with data, research of reasonable quality. And what you'll notice is for premenopausal women, spironolactone and topical minoxidil are at the top. And for postmenopausal women, topical minoxidil, spironolactone, and oral finasteride are at the top. And so the question asks, how do you decide about oral minoxidil or spironolactone? And so you can see in these diagrams, oral minoxidil is nowhere to be found in first-line treatments, in my mind. That's because oral minoxidil is a second-line option in my clinic. Oral minoxidil is popular, extremely popular. It is the most popular treatment for androgenetic alopecia. But that doesn't necessarily reflect where it sits in this treatment algorithm. Topical minoxidil is fairly equivalent to oral minoxidil. It just depends on what dose you use. If I use 5% minoxidil twice a day, or I use 0.0001 milligrams of oral minoxidil, guess what's better? The first one. But if I use 1 drop of minoxidil topically, or 2.5 milligrams of oral minoxidil, guess which one's better? The 2.5 milligrams of minoxidil. So it depends a little on the dose, doesn't it? But with standard dosing, it's not necessarily that oral minoxidil is better, groundbreakingly revolutionary. No, it's just different. It offers different advantages. But we'll take a look at this important concept. But you can see that for premenopausal women, spironolactone and topical minoxidil are at the top of the list. There is no treatment for androgenetic alopecia in women that has better evidence from randomized controlled trials over 25 years than topical minoxidil. It's hard to debate that. In the public's eye, the view on topical minoxidil is, it doesn't really work so well. A lot of people don't get benefit. You got to use it forever. What a terrible treatment. The reality is every treatment you see on this slide is forever. So we take that out of the debate. Every treatment is forever. The reality is when you look at any study of any of the treatments and look at how good are the studies, what's the quality of the study, what you quickly realize is that, well, the data is kind of weak. But there's dozens of high-quality randomized controlled trials of topical minoxidil. And so the confidence level on how well this works and how reliable it is quite good. And so in my clinic, oral minoxidil is a second-line treatment. This study in 2020 by my colleague in Brazil, who is really the leader in performing these randomized controlled trials of oral minoxidil, Dr. Ramos, has shown that oral minoxidil at 1 milligram is pretty similar to 5% minoxidil once a day. And so if a person uses 5% minoxidil once a day, they can expect similar results as 1 milligram oral minoxidil once a day. These are females. So you can see that oral minoxidil is not necessarily better, it's just different. What about if I use 5% minoxidil twice a day? Would it be better than 1 milligram? Probably. What happens if I use 2 milligrams? Would it be better than 5% minoxidil once a day? Probably. But the important point to realize is that 1 milligram of oral minoxidil is pretty similar to 5% minoxidil. But they're different. People that take oral minoxidil are more likely to get fluid retention, hypertrichosis or hair where they don't want it, more likely to get an increased heart rate. And in this study, people that were using the lotion, 5% minoxidil lotion, were more likely to get scalp itching. And so the treatments are different and they offer different advantages. But the public's view on oral minoxidil is it's revolutionary, groundbreaking, the best treatment that exists. Some of that is perception, but we need to talk about the doses when we talk about oral minoxidil. And for women, 1 milligram is similar to 5%. So what are some of the reasons I wouldn't give oral minoxidil to a female? Well, they're listed on this slide. Someone who's planning pregnancy or is pregnant or is breastfeeding, we don't use oral minoxidil. Sometimes we will use topical minoxidil in breastfeeding, never in pregnancy. But again, those are taken on a case-by-case basis. Someone who has problems with fluid retention, we don't use oral minoxidil. Someone who doesn't want to use a treatment long-term is not a candidate for any treatment, because every treatment's long-term. People with heart problems, arrhythmias, cardiovascular disease, we have to be careful with oral minoxidil. The older and older you get, the more careful we have to be with oral minoxidil if there's underlying cardiovascular disease. People with kidney problems or liver problems may not be a good candidate. What about spironolactone? Well, the list is similar with spironolactone, but not identical. We don't use spironolactone in pregnancy. We don't use spironolactone if there's kidney problems or a person is using blood pressure medications that affect potassium. We have to be careful because spironolactone can affect potassium. People with estrogen-dependent cancers, breast, ovarian, gynecologic cancers, we have to be careful. We don't have a lot of great evidence that they cause cancer at all. In fact, some good studies have suggested they don't cause cancer. But these are in women with average risk. We do not know in women with high risk of cancer, someone with a mutation in BRCA1 or BRCA2, some of these genes that increase the risk for breast and ovarian cancer. We do not know in women at high risk if spironolactone is safe or not. In the general population, in women at average risk, it doesn't seem these medications increase the risk of cancer at all. But we don't know about women at high risk. Spironolactone can sometimes cause fatigue and mood changes, sexual dysfunction. And so if someone has fatigue and mood changes and sexual dysfunction to begin with, spironolactone may not be the ideal treatment option. It presents a relative contraindication. And so thank you so much for this question. How do we decide on minoxidil versus spironolactone? Well, topical minoxidil and spironolactone are first line. Oral minoxidil is generally second line. But there are reasons why we don't use spironolactone, and there's reasons why we don't use oral minoxidil. So if someone comes in to see me, they are absolutely against topical minoxidil. They don't want to use it. They don't like things in their hair. And they're on a blood pressure medication that affects potassium. They've had problems with potassium. They've had problems with mood changes and depression. And they have chronic fatigue syndrome. Spironolactone will be bypassed for oral minoxidil. So this is the type of thinking that goes into choosing treatment. Question 5. How do you transition your patients from topical to oral minoxidil to minimize the shedding period? This is a really important question that is relevant to patients and practitioners. If a patient is on topical minoxidil and says, I want to do oral minoxidil, how do you transition them? Well, this really important study by Dr. Losico, first author Noria and colleagues, was a really important study published last year in JAD International, a journal of the American Academy of Dermatology International. And what this study looked at is, if you're switching someone from topical to oral minoxidil, should you keep the topical on board for a little while as they switch? Is this going to help reduce dread shed or shedding? And what this study showed is, doesn't seem to. If you're going to switch from topical to oral minoxidil, just switch. You don't have to keep the topical on for 4 weeks or 2 weeks, or dose the topical from once a day to once every other day. You don't have to do anything fancy because it doesn't matter. Now, this was a fairly small study overall, I think about 115 patients. But the message is important. We don't really have any evidence that fancy dosing of topical minoxidil helps you wean off and get on oral minoxidil any better. But there's a couple of important considerations. The Ramos study in 2020 that I mentioned says that 5% minoxidil is pretty similar to 1 milligram. And so if you're going to switch from 5% once a day to 1 milligram, you can probably just stop and start. But suppose a patient is using a lot of topical minoxidil, and some patients do. Suppose the patient is using 35 drops of topical minoxidil lotion, 1.2 mils or 3 mils or 4 mils. They're using a generous amount of minoxidil topically. Guess what happens if they now switch to 1 milligram of minoxidil? Well, the scalp isn't happy. The scalp isn't happy because the hair follicles say, you owe me more minoxidil. 5% minoxidil once a day is equivalent to 1 milligram. If you're going to switch from 5% twice a day and lots of it, well, the equivalent dose is going to be much higher than 1 milligram. And so where a lot of people go wrong is in these patients that are on high doses of topical minoxidil. And some of our patients are. There are some patients that come to see me and they're using 2 caps of minoxidil a day. Now that's above the recommended dose, but some people do. And it's critically important to realize that if you switch to a low dose of oral minoxidil, that low dose doesn't compensate. And the hairs are unhappy. And you get shedding. And sometimes you even get regression of the hair loss. And you get more hair loss. So we need to understand these beautiful studies by Dr. Ramos quite well. And that is that in women, 1 milligram is equivalent to 5% once a day. Question 6. Very similar theme. What is the proper starting dose of oral minoxidil? Well, the proper starting dose is around 0.6 to 1.25 in women. That's different than in men, where the starting dose is generally 2.5. It is true we can go up to 2.5 in women. It is true that many women around the world are started on 2.5 and do well. Absolutely. But in my opinion, the starting dose of oral minoxidil in women is 0.6 to 1.25. Having treated large numbers of women with oral minoxidil, I can tell you one thing. Side effects are uncommon when you're at 1 milligram, 1.25 milligrams and less. Side effects become more common when you go above that. Doesn't mean they will occur, but they become more likely. Fluid retention becomes more likely. Puffiness around the eyes becomes more likely. Hypertrichosis or hair on the face and body becomes more likely. And so people often say to me, you know what? I'm on 2.5 milligrams and I'm doing great. So I don't like your slide. There are many people that do just fine on 2.5 milligrams. But there are a lot of people that do not. There are a lot of people that go from a shoe size of 6 to 8. There are people that go from small feet to puffy feet. There are people that go from skin that's tight around the eyes to skin that's very puffy. From fluid retention when you go beyond 1.25. Fortunately, it doesn't happen in everyone. But when you treat enough patients, you see it. When you treat enough patients, you see the emails, you see the phone calls, you experience this. And so that's why when this question comes in and says, what is your starting dose in women? It's 0.6 to 1.25. And in North America, these pills generally come as 2.5 milligram pills. In other countries, they come as different sized pills. But they come as 2.5 milligram pills. So if you cut it in half, that's 1.25, and that's a good starting dose. And I generally have patients continue that for 3, 4 months, 5 months. And if you're doing great, no side effects whatsoever, then we may go up to 3/4 of a pill, which is 1.875. And if you're doing great after 3 more months, then we might go up to 2.5. But if you're not doing great and you have fluid retention, we don't go up. So that's my approach to oral minoxidil. I think one of the biggest problems with oral minoxidil, in my opinion, is that the doses are too high to start. And that's where we get these problems. Question 7. Question 7 reads, my 13-year-old daughter has diffuse hair loss since age 9. She's been diagnosed with androgenetic alopecia and anagen effluvium since mid-2024. She's on 2% minoxidil. Is the hair loss reversible? Are there alternative treatments? So thanks so much. This is a really terrific question for so many people to reflect on, including practitioners. It's unlikely that anagen effluvium is the correct diagnosis. It probably is meant telogen effluvium. Anagen effluvium can occur in people, but it's usually from chemotherapy, toxins, things that really damage the hair follicle. It would be very strange in a 13-year-old to have anagen effluvium without some kind of history of being on chemotherapy or some drug. So most likely this is a typo or spelling issue that means to say telogen effluvium. This is a 13-year-old with androgenetic alopecia on minoxidil, which is a very appropriate treatment for teenagers. Is the hair loss reversible? Well, the hair loss may be improvable, but the hair loss isn't completely reversible. But there can be remarkable improvements, and the treatments will be lifelong. And so we'll talk about some of the treatments in a minute, especially the alternative treatments. But in a question like this, with a 13-year-old with hair loss since age 9 on minoxidil, again, what I really need is a story. What happened at age 9, 8, 7, 6, 5? I need to see the scalp to rule out any other diagnosis. But for now, we'll assume it's androgenetic alopecia and telogen effluvium. And then tests, blood tests. In a question like this, several blood tests are needed. Of course, we need blood tests for iron and thyroid and, basic dietary related blood tests. And likely those have been done and likely they're normal. But in children that develop androgenetic alopecia, we need hormonal tests for testosterone and DHEAS. We need blood tests to rule out some endocrine disorders. One of them is called late onset congenital adrenal hyperplasia. We need to have blood tests to evaluate for testosterone and the possibility of polycystic ovarian syndrome, which can be challenging to diagnose in a adolescent, especially at age 13. But we have to be thinking about underlying endocrine disorders. And sometimes in situations like this, a referral to an endocrinologist is helpful, and possibly that has been done. But the story does matter. In someone who develops androgenetic alopecia at age 9, the things that are important is, when did puberty happen? When was the first period? Was it at age 12 or 13, or was it at age 10, 9, 8? What age did this individual enter into puberty? How has the height changed? Was this individual very tall at age 7 and 8, tallest in the class? All those pieces of information are so important. At age 13, does this individual have acne, hair on the face, obesity, diabetes, insulin resistance? All these things matter. So the story matters greatly. And they affect the treatments that we give. But in general, teenagers and children that develop androgenetic alopecia at young ages need a proper endocrine workup. That doesn't mean that every single child and teenager needs to see an endocrinologist, but there's a very low bar to send the referral in to rule out underlying disorders. And in children and adolescents with androgenetic alopecia, we want to make sure there's no factors that are driving the androgenetic alopecia to go faster. Things that cause shedding make androgenetic alopecia worse. So poor diets, stress, weight loss, smoking, obesity, these are factors which are going to drive the androgenetic alopecia to move along a little faster, and maybe seborrheic dermatitis or dandruff as well. So those need to be addressed and dealt with. So now we come to the question, what alternative treatments are available? Well, minoxidil is being used at 2%. Certainly there's an option to go from 2% to 5%. Oral minoxidil is an option. Spironolactone is an option. Low-level laser therapy is an option. And depending on the exact history and what the endocrinologist says, if an endocrinologist is involved, in some cases, an oral contraceptive is administered, prescribed. Not always to a 13-year-old, but it's possible. It just depends on the situation. If there is an underlying endocrinopathy or hormonal issue. Nothing else has good evidence in teenagers. And so if you say, you know, Dr. Donovan, the one thing you don't have on this slide is it doesn't have good evidence. Yeah, but you didn't let me finish. Of course I would let you finish, but it doesn't have good evidence. Microneedling, rosemary, some other shampoo, some other supplement, some other something. It does not have good evidence in a teenager. The treatments that have good evidence are the treatments on this slide. Oral minoxidil and spironolactone and topical minoxidil having the best evidence. This was a really nice study in 2021 in the Journal of the American Academy of Dermatology, and I believe this paper is free online if you type it in. And what it showed is 6 individuals, 6 females, who were on topical minoxidil or spironolactone or a combination thereof, and they weren't getting better. And so these dermatologists put them on 2.5 milligrams of oral minoxidil and 50 to 100 milligrams of spironolactone, spironolactone being an anti-androgen. And all 6 of these individuals improved, 5 quite a bit, and 1 maybe a little bit. And these treatments were quite well tolerated. And so we don't have studies of oral minoxidil and spironolactone in adolescent females in the hundreds of patients or thousands of patients, but we have some data. The first-line treatment option is definitely topical minoxidil in an adolescent. And so when I see teenagers, children with androgenetic alopecia, and they haven't started any treatment, the first step is easy. That's topical minoxidil. But the second step, which is where you're at now, is a little trickier, but for females, you know, maybe oral minoxidil and or spironolactone. And in this case, they did both. And it's very reasonable. Children and teenagers are different than adults. Dosing is different. Side effects are different. But in general, teenagers tend to tolerate these medications better than adults. And so we see much less fluid retention. We see much less issues in general with oral minoxidil and spironolactone than in adults. But they can occur. Hypertrichosis can occur, hair where you don't want it. But this was such an important paper because it reminds us that spironolactone and oral minoxidil are off-label treatments, but they're reasonable to consider in a teenager. Topical minoxidil is also off-label in a teenager. There's no treatments that are approved, but topical minoxidil is first line in a teenager. Thank you for that great question. Question 8. I have been taking 5 milligrams oral minoxidil for 3 years, but I'm still experiencing progression of male balding. As I'm not taking a DHT inhibitor, is there any point to taking oral minoxidil? As I've read that oral minoxidil does not stop progression, it thickens the hair follicle from additional blood flow. But is there any merit to making that hair follicle thicker if it's likely that it will just fall out? Anyways, due to it not being protected by a DHT inhibitor. This is such an important question because a lot of what's resonating from this screen to me is myth. Public myth that's carried on, story after story. The stories we share with each other over coffee, over dinner. This is what's passed down. Humans are good at that, aren't they? Sharing stories, passing information. We do that on forums. We do that on Reddit. We do that on other social media sites. And this is one that's a little bit skewed in its interpretation. And there are some individuals which really have the view that the entire story of male balding is all DHT. DHT, DHT, DHT. Everything's DHT. And it is absolutely true that DHT is extremely important. Absolutely. There's no arguing with that. DHT is a hormone, dihydrotestosterone. Testosterone is converted to DHT by 2 enzymes, at least 2 enzymes. And it's this DHT hormone that causes hairs to miniaturize in males. But there are some individuals which have the view that it is only a DHT story. And I need to be on DHT everything, DHT blockers, DHT shampoos, DHT, anything DHT. The thing that is neglected in this type of reasoning is there may be other mechanisms which are extremely relevant in androgenetic alopecia. And so for males, this is my approach to male balding. First line options are topical minoxidil, oral finasteride, dutasteride, topical finasteride. Second line options are oral minoxidil, PRP, and laser. Now, that doesn't mean that every male is started on finasteride or dutasteride. Absolutely not. The treatment algorithms depend on the story. The treatment algorithms depend on someone's risk tolerance. Treatment algorithms depend a little bit on age, severity of hair loss. All this influences what we start. A 16-year-old male that comes in to see me with androgenetic alopecia, topical minoxidil is first line. But you can see that in this slide, there are many treatments on this slide that are not classic 5-alpha reductase blockers, drugs that don't interfere with DHT. Topical minoxidil, for example, oral minoxidil, PRP, laser. These are still helpful treatments. And they may play a very important role in androgenetic alopecia by encouraging the anagen phase to elongate, which may play a very important role in reducing progression of androgenetic alopecia. And so if someone with androgenetic alopecia can improve their hair with oral minoxidil, then I'm happy. Even if they don't have a 5-alpha reductase inhibitor on board, I'm happy. We will, of course, be taking pictures yearly, sometimes every 6 months. We will, of course, be following the progression very closely. But am I too bothered that that person in room 7 is on oral minoxidil, laser, PRP? If they're getting better, I'm pleased. Yeah, but don't you worry that they're not on a 5-alpha reductase inhibitor? Not at all. They're getting better. So it absolutely is true that DHT plays an important role. But there may be other mechanisms involved as well that play an important role in some males. Now, it's absolutely true in some males, blocking the DHT pathway is critical, but not in all. And so one should not neglect these other treatments if they are proving helpful. Now, you can see that in 2025, 2023 on this slide, oral finasteride and dutasteride are still at the top of the list for the most effective treatments. There is nothing more effective than dutasteride for male balding. Nothing. There's no debate. You show me any study, any trial, there's no debate. And so that remains an important option. We're going to get to side effects in just a minute. If I'm still experiencing hair loss despite being on oral minoxidil, how will I arrive at the conclusion that it's not working? It's unclear with oral minoxidil, as some say it's slowing hair loss and not stopping it. This is a great question because this introduces how challenging it is to monitor hair loss. So let's say, for example, without treatment, without any treatment, this is the speed of decline of hair density. The hair density gets less and less and less and less. If oral minoxidil is used in this example, the hair still gets less and less and less. So the feeling is, it's not working. I'm wasting my time by using this treatment. But notice that the speed of hair loss is less. Instead of being significantly bald by 58, the individual is thinner, but much less bald at 58. Because oral minoxidil has slowed the speed of hair loss. That is challenging to decipher, and some of that comes from experience and dialogue between the clinician and the patient. Let's see your hair in 2020, 2021, 2022, 2023. Let's look at it now. Okay, it seems to have slowed. And sometimes over time, you can get a sense of that, but it can be challenging. So I really appreciate this question because it is challenging sometimes. And that is why I don't like patients to give up on treatments too soon, especially if they're not having any side effects, because it can take time to evaluate the effectiveness of a treatment sometimes. Question 10. In an article on finasteride or dutasteride that you wrote, you said the following: some people should never use these drugs, ever. So consult with an expert before putting anything in the body. In view of this, which could you clarify who should never take this drug? So thank you. That's absolutely correct. You know, these are prescription medications. And they are prescription medications because health agencies around the world, whether Health Canada or the FDA or European Commission or you name it, those countries have said this cannot be over the counter because it must be monitored. And because it's not over the counter, it's just a reminder to the population that there needs to be some intellectual input here and discussion about risks and benefits, and that must take place. Finasteride can cause mood changes, depression, enlargement of breast tissue, sexual dysfunction, reduced sperm count, and in some cases, reports of post-finasteride syndrome where symptoms persist after stopping. These have been reported. And so every single person that starts finasteride or dutasteride must know about this. They must know about the risks of depression, the risks of sexual dysfunction, and they are low, but they're not zero, but they're low. And so if someone starts finasteride and they've never heard about PFS, they don't know even what it is, then, at least in my view, that may be an issue. Because starting finasteride and dutasteride is all about informed consent. And there are some individuals who will say, even if it's a 1 in a million risk, it's not for me, Dr. Donovan. And there are other individuals that will say, even if it's a 1 in 2 risk, I would like the prescription, please. Because hair matters differently to people. And that's something that's often neglected when we think about these issues of side effects. Everyone's risk tolerance is different, dramatically different. But I think that all of this is about informed consent, that if you're starting finasteride or dutasteride, you just need to be aware of these and come to engage in that discussion with your practitioner about what is right for you. What are you going to do if this happens? Is that risk acceptable? There's a 1 in 300 chance of gynecomastia or breast tissue enlargement in males. 1 in 300 to 1 in 1,000. Is that low or is that high in your mind? For some people, that's way too high. I don't want this. For some people, that is low. That's like 0. So let's start. Everyone's risk tolerance is different. But I don't give finasteride to people that have severe depression that's not treated. And the question always comes out, yeah, but what about Dr. Donovan, a person with severe depression on an SSRI, doing better for the last 5 years, under routine surveillance by a psychiatrist? Well, these are all taken on a case-by-case basis, aren't they? But guess what? In these severe cases, I'm in constant dialogue with the psychiatrist. Hello, dear psychiatrist. This patient would like finasteride. Finasteride can affect depression. We've had long discussions about this treatment, and my concern is that, could this person's mood be affected by finasteride? So many of these aren't decisions that I will enter in myself, but rather in collaboration. Someone who has fertility issues and is planning to father a child in the very near future, finasteride's not a good option. Finasteride may reduce sperm counts temporarily. So you can see that this is a prescription medication which really requires appropriate counseling. And so it's not for everyone. And there are some people who should not take finasteride. If someone cannot accept those risks, then that finasteride is not for them. I sure hope this never happens to me, Dr. Donovan. If it happens to me, I'm going to be so upset. I really don't want it to happen to me. I'll be so mad. It's not for you. All medications have some risk. All medications. And it comes down to, what is the risk? What is the number? What is the statistic? How does that sit with you? But prescribing finasteride requires a story and an exam and a test. And in this particular question as well, I would need more information to guide further. Question 11, I'm on the fence whether to start PRP. I saw that you said there isn't a standard formula for PRP. That's right. There's thousands of ways to do PRP. Thousands. The way I do PRP is different than someone else does PRP just down the street. And you can imagine across the world how many PRP protocols there are. There's 100,000 PRP protocols. So when someone says to me, what do you think about PRP? My initial feeling is, well, which of the 100,000 protocols are we talking about? There's nothing standardized. In view of this, is it better not to bother with it and focus on treatments that we do have good evidence for, like minoxidil or DHT inhibitors? This algorithm here reminds us of where we start our thinking. And for male balding, we start our thinking in the first line options: minoxidil, finasteride, dutasteride, topical finasteride. And if these have been used, or they're deemed not appropriate, a person does not want them, then we move into the second line options, which include laser, PRP, and oral minoxidil. Now, it could be that we do topical finasteride with oral minoxidil, with laser, and then the person isn't getting better, or they've gotten better, but they want to get even better. What do they have available? Well, PRP is sitting here. Do you mean to tell me that you would rather do PRP in your patient before moving on to something else like minoxidil with microneedling or Botox injections in the scalp? Absolutely, because it's a second line option. If I really thought that something like microneedling or Botox was better than PRP based on evidence in 2025, I would put that in the second line category, and I would remove PRP and put it in the third line category. But this diagram shows the algorithm based on the efficacy of treatments coupled with safety, affordability, feasibility, and effectiveness. And so these diagrams take a while to digest, but they're powerful diagrams because they offer guidance of a large body of literature, a large body of published research spanning 30 years. And every year, these slides change depending on new research. Question 12. I'm considering starting 0.1% topical finasteride. How safe is topical finasteride? Well, we set out to address this question. Adam Bai is a medical student at the University of Ottawa. Just a brilliant medical student who, together with Ryan Gang, we looked at the published randomized controlled trials of topical finasteride and looked at the safety. And what we found is that safety is pretty good. So why did we set out to do this study? Well, topical finasteride is becoming quite popular throughout Europe. Many countries are approving topical finasteride. And it's taken on a country-by-country basis throughout Europe. But recently, the FDA came out with this caution. They cautioned against topical finasteride. They were concerned about reports of sexual dysfunction, depression, skin reactions. And so as someone who prescribes topical finasteride, my feeling when the FDA published that caution, meaning they're going to watch for this, they're not sure about this, they issued a warning to the public, let's watch for this. My feeling was, I'm certainly not seeing the same degree of sexual dysfunction, depression that I see with oral finasteride by any stretch. So what does the literature, what does the published research show us? And so we set out to perform this systematic review and meta-analysis to look at all the published studies. We found 6 randomized studies with 1,104 men. And what we found is that compared to placebo, topical finasteride did not increase the risk of erectile dysfunction, decrease libido. There were no reports of depression. And despite the concerns from the FDA about skin reactions, we didn't see an increased risk of seborrheic dermatitis, itching, and redness compared to placebo. And so in this particular study, we didn't find that topical finasteride really had a concerning signal, at least in these randomized trials. Now, of course, more studies are needed. Of course, close monitoring is needed with any medication. But the safety seems quite good for topical finasteride. Question 13. I read your paper on minoxidil being toxic to cats. It has certainly got me a bit worried as we have 2 cats in our home. Can you review again just how big of a concern this is? So thank you so much. Several years ago, I became aware of some really interesting studies in the literature, the veterinarian literature, by veterinarians about the toxicity of minoxidil in cats and dogs. But this information was largely in the veterinarian literature, so it's well known to veterinarians, but really not well known to the public and not well known to the people that are prescribing it and recommending it. Hair specialists, family physicians. And so, together with Dr. McMullen, superstar dermatology resident at the University of Toronto, and colleagues across the country and in the United States, including veterinarians, we set out to review all of the studies of toxicity in cats and dogs. And what we found is that the overwhelming message is that minoxidil is toxic to pets. It's more toxic to cats than dogs because cats lack a specific enzyme to metabolize the minoxidil. But topical minoxidil can affect the heart and the lungs and the kidneys and the liver, and it can make pets really sick quite soon after exposure in some cases, within 30 minutes. And in total, we reviewed, just under 100 pets that had been reported. And 15% of cats with minoxidil toxicosis ended up dying. There were no deaths in dogs, but dogs still were quite sick in many cases. And so it was a really important reminder that topical minoxidil is toxic to pets. And we need to counsel patients about all the side effects of minoxidil. It can cause shedding in the first month you use it. Some people get headaches. Some people get too much hair on the face. This is important. But we need to take the next step and ask, do you have pets? And are you aware of the importance of keeping minoxidil away from your pets? Even a single lick from a cat can be fatal. Now, dogs tended to get sick by going through trash and finding tissues that had extra minoxidil on it from the pet parent. But cats got sick by licking skin, licking pillowcases. And so there's no easy answer, but what is clear is that if minoxidil users have cats, minoxidil must not come into contact with the cat. So if the cat sleeps on the bed, that may be an issue. If the cat has exposure to bottles, that may be an issue. Things need to be kept away. Pets need to be kept off the bed, kept out of the hair if the user is using minoxidil. Now, in some case, that just involves reflecting on how one uses these and just developing more strict policies in the household and how you do things. But sometimes it involves making a decision that maybe this isn't safe for me, or maybe I need to change to oral minoxidil, or maybe I need to not allow the cat to sleep on the bed. And so thank you so much for this question. This paper, Dr. McMullen's paper, really has resonated quite well, around the world. And we really had hoped that it would draw attention to this. And the thing we're working on now is to get, these regulatory agencies to really be stricter with the product monographs. When you look at many of these product monographs, when you open up your minoxidil leaflet, you don't see anything about a cat and a dog in that leaflet. You see all the studies, all the side effects, all of this, but you see nothing about a cat or a dog. And this needs to change. And there's a lot of steps to get that done, and it's been quite difficult. But together as a society, perhaps we can work collaboratively to protect our pets. And so minoxidil is toxic to your cat. And your cat can't come into exposure with minoxidil. And even a single lick can be harmful. And so these are tough. These aren't easy conversations. These aren't easy discussions. Let's move on to alopecia areata. Alopecia areata is an autoimmune disease. It affects children, affects adults. People lose hair often in patches or circles. It can affect the back of the scalp, the front of the scalp, eyebrows, eyelashes, many places. It's an autoimmune disease. It affects about 2% of the world. So someone's emailed in saying, are topical JAK inhibitors just as good as oral JAK inhibitors? JAK inhibitors are a group of treatments that suppress the immune system. Some of the oral JAK inhibitors like baricitinib and ritlecitinib, truxolitinib have recently become FDA approved and Health Canada approved for alopecia areata. Severe forms. But what's really important is to realize that topical is not as effective as oral. And that may be because the inflammation, the autoimmune inflammation in alopecia areata is quite deep. At the bottom of the hairs, if this is a schematic diagram of the skin with hairs, the inflammation in alopecia areata is way down deep. And when you put a cream on the surface, it dissolves a little bit. It's hard to get it down to the bottom. And that's where the inflammation is in alopecia areata. And that may be why they're less effective in alopecia areata. But they still can be effective. When you have a patch on your eyebrow, sometimes topical JAK inhibitors are a great option. For children, sometimes when you have small patches that just aren't responding to localized steroid treatments or other treatments and you're not sure what to do next, sometimes topical JAKs can be an option that can be helpful in a small percentage, but they are not as effective as oral agents. And so that's a really important concept. It's an exciting world of JAK inhibitors. We're going to see many more being approved over the next short while. So stay tuned. It's an exciting time. So now we move on to scarring alopecias. I'm going to talk about a scarring alopecia called lichen planopilaris. This is an up-close exam photo of lichen planopilaris. You can see the scalp is red. There's scale around the hairs. Some hairs are twisty, bendy, and some hairs are missing. These are the scarred patches in this scarring alopecia. Lichen planopilaris is a scarring alopecia that permanently removes hair. And so the question that has come in is the following. I'm a 42-year-old woman with hair loss for 4 years. A recent scalp biopsy makes me wonder about LPP or lichen planopilaris. A recent scalp biopsy showed a fairly normal number of follicles with a mild catagen-telogen shift. The pathologist noted mild perifollicular inflammation in the upper isthmus and some mild perifollicular fibrosis. Sebaceous glands were preserved with a terminal to vellus ratio of 2.1 to 1. Does this sound like early LPP to you? Does this sound like an early scarring alopecia to you? Is the question. And so the answer is no. Scarring alopecias are autoimmune or immune-mediated diseases that lead to loss of sebaceous glands in many cases. And so when I see sebaceous glands are preserved, and I see a biopsy showing a fairly normal number of follicles, in other words, they're not gone, my feeling is, well, this isn't a highly destructive process that's destroying hairs. So this does not read like a scarring alopecia. When we see preservation of sebaceous glands, it makes a scarring alopecia much, much less likely. Rather, this sounds like androgenetic alopecia. And so what happens in androgenetic alopecia, or female pattern hair loss, male balding, is the hairs get skinnier. And another way of saying hairs get skinnier is saying the terminal to vellus ratio drops below 4. So in early balding, the terminal to vellus ratio might be 4 to 1. As balding progresses, it gets less and less, 3 to 1, 2 to 1, 1 to 1, and might even flip. And so this is a helpful slide that compares the pathology features in androgenetic alopecia, telogen effluvium, alopecia areata, and lichen planopilaris. And so this individual in this question is asking, does my biopsy sound like LPP? Well, in LPP, we don't generally see miniaturized hairs necessarily, but that's a feature of androgenetic alopecia. But sebaceous glands are lost in LPP. They're not lost in androgenetic alopecia, telogen effluvium, or alopecia areata. So that's a really important feature. This biopsy has no loss of sebaceous glands. A mistake that's often made is that androgenetic alopecia can have inflammation, just like LPP. Now, the inflammation is a little different sometimes, that's true. In LPP, there can be what's called lichenoid inflammation with actual death of keratinocytes, but you could still get inflammation. And in LPP, you get scarring or fibrosis around the hairs like a blanket. But sometimes in androgenetic alopecia, you get some mild perifollicular fibrosis as well. And so mild perifollicular fibrosis and mild inflammation doesn't really bother me too much that we're missing LPP as a diagnosis. And sometimes in androgenetic alopecia, you do get a little bit of a catagen-telogen shift. In other words, you get a few more shedding hairs in the biopsy. That's classic in telogen effluvium, but you see increased catagen and telogen hairs in alopecia areata, sometimes in LPP as well. And so this is a biopsy showing reduced terminal to vellus hair ratios, preservation of sebaceous glands, and that's more typical of androgenetic alopecia. We move on from LPP to frontal fibrosing alopecia and some questions that have come in about FFA. Frontal fibrosing alopecia is a condition that affects women and men, but women much more than men. It often causes hair loss in the eyebrows to start. And then over time, the frontal hairline gets affected. But frontal fibrosing alopecia is an extremely complex condition with over 40 other associations in the body. Some patients will get veins showing on the face. Some patients will get a forehead groove. Some patients will get facial papules. Some patients will get loss of arm hair and leg hair. Some patients will have thyroid disorders. Some patients will have early menopause. Some patients will have a whole host of systemic issues. And so frontal fibrosing alopecia is a complex disorder that is called frontal fibrosing alopecia because one of the original findings was this scarring along the frontal hairline. But it's now realized that, wow, it's really quite a complex disorder. And so the question has come in, are there any promising new treatments for FFA? And the answer is yes. But I think the thing that I see day in and day out, because I treat large numbers of patients with FFA almost every single day that I open the door to my office, is it is true there's new treatments on the horizon, but I think that the current treatments are often not used appropriately and effectively. And so it is true there's new treatments are coming, but as we'll see in just a minute, even the current ones are not used properly. And so in many ways, my goal and my hope is that we can encourage practitioners around the world to use the current treatments more effectively and continue to research new and better and more effective treatments. Yes, that's how we advance science. But even the current treatments are not used properly enough. So these are my first line options for frontal fibrosing alopecia. And again, these may not be appropriate for everyone with this disease, but some of the most effective treatments for FFA in 2025 are dutasteride. Isotretinoin can be very effective as well. Topical calcineurin inhibitors like pimecrolimus and tacrolimus, and steroid injections. There can be side effects with these treatments. But I think what's important is to realize that when you actually look at the evidence, the research that supports these treatments, it is sufficient to support these being first-line treatments. My second-line options are quite involved, aren't they? Look at all the treatments in this category. Topical JAK inhibitors, topical tofacitinib, topical ruxolitinib, hypoallergenic shampoos, hydroxychloroquine, which also goes by the name Plaquenil, doxycycline, topical and oral minoxidil, spironolactone, quite a long list. Now, topical JAK inhibitors are very popular right now in FFA. And in some clinics, we're seeing a trend where some practitioners view these as first-line agents. And I respect that. I think that's, not unreasonable. Everyone's out to help the patient and, put the patient's needs first. But in my opinion, when you actually look at the literature and you look at the quality of the evidence and the length of studies and the data, topical JAK inhibitors are helpful, but they're not as effective as dutasteride. They're not as effective as steroid injections. They're not as effective as isotretinoin. And so they're still helpful, but they're second-line agents. And so I reserve them in the event that these are not possible to use or they've been used and are not completely effective. So I use a lot of topical JAK inhibitors in FFA, but we often don't start there. We start with one of these in this first category. But the question actually asks us, what new treatments are coming? Having lectured on FFA for, almost 10 years now, consistently, the thing that's so clear is we don't universally understand the treatments for FFA. We don't universally administer these treatments for FFA. And so my hope as step one is that we can use these treatments that you see on this slide better and use them and do it. It is important to search for new treatments and novel treatments, absolutely. But how much good we can do actually by using the things that are on this slide first. And that's really an important step one in my view. But the things that are being researched very actively are the topical JAK inhibitors, the systemic JAK inhibitors, and there's more systemic JAK inhibitors coming. Right now we have data on tofacitinib, baricitinib, but look at all the JAK inhibitors that are there now. Upadacitinib, ritlecitinib, abrocitinib, duruxolitinib. There's so many. There's topical tofacitinib and ruxolitinib as creams. Topical delgocitinib is another JAK inhibitor, which was just approved in Europe and the United States for treating hand eczema. And many people are excited to try to see if this topical JAK inhibitor will have benefit in FFA. So tremendous excitement around the world. And there are some studies underway already looking at that. But as we continue to try to understand what causes FFA, there's a lot of, interesting treatments that are emerging as we think about new mechanisms and new treatments, including treatments that try to block fibrosis. These may have an important role in the future. But the thing that's so important to remember, and something that is a fundamental principle in my clinic, is I'm not always looking for the one treatment that solves everything, but rather a multitude of treatments that in combination can help. And this diagram sort of reminds us, if this dark gray creature is the immune system, are we looking for one single powerful drug that blocks it? Or what happens if we could block this same creature, this same scary creature, with many little safe treatments? And wow, wouldn't it be great if we could use many safe treatments to say to the immune system, stop? Now, it's sometimes inconvenient to use many treatments. It'd be easier just to use one. But if that treatment has potential side effects, it's kind of a debate as to whether we should use that or aim for many safer treatments. And so when we look at all the treatments we have for FFA, you can see on this list that there's some that are very safe. A switch to a hypoallergenic shampoo, devoid of fragrance, devoid of preservatives. Well, that's pretty safe. Does it really do anything? For some patients, absolutely. You mean to tell me that simply going to buy another shampoo can help FFA? For some people, absolutely. So that's a pretty safe option. Research has looked at other options that modulate the immune system, like low-dose naltrexone. And one of our recent studies showed that, low-dose naltrexone can be helpful for both FFA and LPP based on all the published research. Side effects are pretty mild, especially when doses are kept low. Some of these low-level laser devices are pretty safe. Now, that doesn't mean these options in orange are as effective as dutasteride or isotretinoin or steroid injections. No. But they can, just like that slide before showed, they can provide safe treatments that do something. And when you combine a multitude of very safe treatments, sometimes we can have an impact on this disease. And so when someone with FFA has improved with dutasteride and topical pimecrolimus, and they say to me, what can I do next? It's not perfectly controlled. What should I do next? Well, let's get you on a hypoallergenic shampoo. Let's get you on a laser device. Let's get you on low-dose naltrexone. And of course, if this doesn't work, then we're going to move on to topical JAK inhibitors, hydroxychloroquine, mycophenolate mofetil in some cases, other more potent immunosuppressants. Absolutely. But it's important to be aware of how to use these treatments. And in amongst this list is some potent immunosuppressants, but in amongst this list are some pretty safe treatments. What is your opinion on the long-term success rates in hair transplants for this condition? This has been a question that's come up quite a few times this week, including at some other meetings. And, I feel very strongly that hair transplants are not an option for everyone with FFA, but there's one criteria that has to be met before we even discuss hair transplants. And that is the disease has to be 100% quiet for 2 years. And what that means is you take pictures in 2023, and you take pictures in 2025, 2 years later, and you compare them. And if those pictures look identical, 100% identical, then the disease may be quiet. But if in 2023, there was actually 2 hairs that were here that are no longer here in 2025, and in 2023, there was actually a little more eyebrow hair, and that's not there in 2025, then the disease is active. And so hair transplants work best when the disease is quiet. And so the first criteria has to be quiet. But hair transplants and FFA are unpredictable. And this was a really wonderful study by my colleague, Dr. Vanyo from Spain and colleagues, published in 2019, so almost 6 years ago. It's a one-of-a-kind study. There are no other studies like this. They looked at how good is hair transplants and FFA. What do we tell patients? Well, they looked at 51 patients, 48 females, 3 males, and patients were followed for 3 years on average, and it ranged from 2 years to 10 years. And all these patients were receiving some kind of medical therapy. After 1 year of observing, a lot of the hairs that were transplanted were still there. 80%, 87% of them survived. Pretty good. But that reduced to 41% after 5 years. And in a small subset of patients, 12, that the authors followed for a long time, the survival was even less of those hairs. And so the authors found that over time, hairs in FFA die off. But what was so important in this study is that of these 51 patients that were transplanted, even though many of them experienced hair loss, the transplant grafts died, some of them anyways. 82% of patients were satisfied with the transplant. They felt it was worthwhile that they went through with this. And so that's really important. So even though 60% of the transplanted hairs died, 80% were happy. 80% of patients. So what this means is that appropriate counseling is really needed. That when patients with FFA are going to have a hair transplant, they need to be aware of these uncertainties. Some hairs may die. Some grafts may be lost. It may look good after the first year and you may be very pleased, but that may not be the way it looks at 5 years. And 20% of patients weren't happy. And so what do those 20% of patients feel? How unhappy are they? And so this is the best study we have in this question so far, but it's a reminder that hairs die. And these are tricky surgeries. And so these are, really lengthy discussions yet that you have to have with patients to really determine, is this worth it for you? And 80% were happy. For 80% of patients, they were happy. So in the final little while, we're going to talk about some questions that have come in about folliculitis decalvans, and we're going to talk about some questions that have come in related to cutaneous pilomigrans. So this picture you see on your slide is folliculitis decalvans, a scarring alopecia that affects the crown, mid-scalp, can affect anywhere. It can affect the beard, arms. But often the crown is affected. Patients develop pustules and crusts. It's extremely itchy, sometimes burning, bleeding. And this slide shows what happens in folliculitis decalvans, and that is that hairs fuse together. You can see in this cartoon, I've shown 2 characters pushing adjacent follicles together, and they fuse together. Normally, hairs come out in groups of 2 and 3 in the scalp, sometimes 1. But in folliculitis decalvans, they fuse together. We call those compounded hairs. So the question that has come in is there a guideline approach to treatment? In your personal experience, what has shown increased rate of remission? So everything we do in hair loss is organized and structured. We don't just pull a treatment out of a hat and say, let's do this. Sounds good. We look in the published literature. We look at all the studies that have ever been done since the beginning of time. And we look at, what has the best evidence, what has good safety, what, has reasonable costs. And we think about all those factors in parallel, and we come up with first line, second line, and third line options. And for folliculitis decalvans, some of the starting options are oral antibiotics, because it's thought that bacteria play a really important role in this disease. Sometimes topical antibiotics, steroid injections, topical steroids, and sometimes oral isotretinoin. Often 0.5 to 1 milligrams per kilogram per day, but sometimes even as low as 0.1 milligrams per kilogram per day. But these are the starting options. And if those aren't effective, then we may move on to clindamycin and rifampin, a well-studied option, powerful option for folliculitis decalvans, but sometimes associated with gastrointestinal side effects, diarrhea. Hydroxychloroquine is on this list based on recent studies, as well as some other antibiotics. But you can see that antibiotics and isotretinoin and steroid injections are first-line options. And so a question has been posed, what is the recommended daily dose of Accutane, which is isotretinoin? And that's 0.1 to 1 milligrams per kilogram per day, generally 0.5 to 1, but it can be as low as 0.1. What is the treatment for pain and itching with folliculitis decalvans? Well, successful treatment of folliculitis decalvans will reduce pain and itching. And so topical antibiotics, oral antibiotics, steroid injections, these can be helpful. And, for the past 10 years, we've been studying steroid injections in folliculitis decalvans. And steroid injections can be very helpful, even at low doses, and quite safe. And many patients can gain quite a bit of relief from pain and itching with steroid injections. That doesn't negate the importance of antibiotics and other treatments like isotretinoin, but steroid injections can be very helpful. And that's why steroid injections are an important part of my treatment algorithm for first-line options. Question 21, is folliculitis decalvans hereditary? Not usually. There are cases, and I think I put them up here. Yeah, there are cases in the literature where there's been a father and son or two sisters with folliculitis decalvans, but most people don't have a family history. And, sometimes in other scarring alopecias, there can rarely be histories. Sometimes in folliculitis decalvans there is. Sometimes in frontal fibrosing alopecia, there's a mother and a daughter or two sisters, but it's maybe less than 10% of cases. Sometimes in central centrifugal cicatricial alopecia, a scarring alopecia in Black women, there can be familial cases, sometimes LPP, but it's certainly less common for folliculitis decalvans. These are the last two questions that have come in. I am a male in my 30s with a long history of scalp inflammation. It began with folliculitis decalvans symptoms and painful bloody pustules, but is now yellow scale dominant with redness and irritation and no blood and less pain. Does the photo I'm about to show you look like the transition into folliculitis decalvans LPP phenotypic spectrum or seborrheic dermatitis, and what's the best treatment? Should I remove crusts? So this individual who sent in this question is telling us about a condition called folliculitis decalvans lichen planopilaris phenotypic spectrum. This is a phenomenon where people start out with a diagnosis of folliculitis decalvans, and then over time, if you rebiopsy it, the biopsy doesn't come back folliculitis decalvans anymore. It comes back lichen planopilaris, so it transitions. And sometimes it can go back to folliculitis decalvans and then back to LPP, but it has this spectrum of presentations. That's called the FD-LPP phenotypic spectrum. And so the individual is saying, take a look at these photos. Does it look like the spectrum? And so here's the crusts. We have all these hairs glued by these crusts. We see the scarring on the scalp in folliculitis decalvans with these yellow crusts, some scale, some yellow crust. When you look up closer, you see some of these scales, honey-colored yellow scales. And in the crown, this is the crown of a male, we see scarring extensive scarring, but these hairs covering and allowing coverage of the crown. And so this individual is asking, is this phenotypic spectrum? Or is this folliculitis decalvans? And the answer is that the LPP phenotypic spectrum, is probably the most likely diagnosis here. But even in the spectrum, there can be areas of the scalp which are more folliculitis decalvans-like, and areas of the scalp, even in the same person on the same day, which are more LPP-like. But with this history, it's likely that this, fits the definition of the spectrum. But when I look at some of these photos, honey-colored crusting or yellow crusting can sometimes be associated with Staph aureus. And so when you have folliculitis decalvans, what's always important for any of the practitioners that are on the call is to think about swabbing for bacterial swabs. Sometimes if you swab and disturb this, sometimes you can get some pus that oozes out, and that's hiding Staph aureus, a bacteria called Staphylococcus aureus. So, in some ways, some of this looks like lichen planopilaris, but some of this does have the crusting and features of folliculitis decalvans at the same time, which of course is the features of the spectrum. But the thing we always have to decide when we treat the spectrum is, do we use treatments that are on the folliculitis decalvans list, or do we do treatments that are on the LPP list? And so the treatment of LPP, the folliculitis decalvans LPP phenotypic spectrum, involves choosing treatments that are on both of these lists. And if something has truly become more LPP-like, and it really doesn't look FD-like, then we're going to choose treatments on here, including steroid injections and hydroxychloroquine. If something still looks folliculitis decalvans-like with pustules, then we might choose something on this list. That's why the swabs are so important in all of these cases. Is there bacteria here? Is there Staph aureus still present? Are there pustules that still come up, even if they're not noticed by the patient? Are they seen on the scalp? Because that may warrant antibiotic treatment for periods of time. But, the things that are universally helpful for both conditions are steroid injections, doxycycline, hydroxychloroquine. You can see those are on both lists. And that's why when I treat many patients with the FD-LPP phenotypic spectrum, I will use hydroxychloroquine, sometimes with doxycycline, sometimes with steroid injections, and because these address both conditions. Now, the very important question has come up is, what do we do with these crusts? The crusts are important to remove. I really am a big believer that these crusts are important to remove. First of all, you can see that the crusts remove hair. But second, these crusts hide bacteria. So these crusts on the scalp, when you lift them off, underneath is bacteria in many cases. So they provide a home, or what we say, a nidus for bacteria. And we want to disrupt that. We don't want to give bacteria a home or a hiding spot. So we want to unroof these. But we want to do it slowly and delicately. So what I often say to my own patients is, we're going to do this slowly. I would like these crusts to be gone in a month. They don't have to be gone tomorrow morning or this week, but we're going to give ourselves a month. And that just as a reminder, we're going to go slowly. So the things that I often will use is dandruff shampoos. Often the scalp is coated with different Malassezia-related yeast. But the things that lift off scales so effectively are salicylic acid. And this is an ingredient often in shampoos. 3% is often added to some of these salicylic acid shampoos, and they can be wonderful to lift off scale. There are some corticosteroid oils like fluocinolone acetonide oils, which are wonderful to lift off scale. And you can use mineral oil and olive oil even coconut oil overnight, put it on your scalp, put a shower cap on, go to bed. And when you shower in the morning, some of that scale just lifts off. And sometimes what I'll do is I will have a patient use one of these oils, either the coconut oil or olive oil or steroid oil, apply it overnight, and then shampoo it out with a salicylic acid shampoo. And some of the salicylic acid shampoos have a dandruff ingredient. And so we might have the patient use a, selenium disulfide containing shampoo with salicylic acid in it, and they shampoo that to help get rid of the oil. There are other things that loosen scale, including urea creams and lactic acid lotions. But it is important to get rid of this scale. It is. And it should be done slowly and delicately. So we're going to come to our last question. And then I'll open the floor to any other questions that have come in that you'd like addressed. We're coming up to our 2-hour mark. So I'll do a short number of questions afterwards. This is an interesting question on a phenomenon called polymigrans, cutaneous polymigrans. And thank you for sending this in. Here's the question. We have had negative responses at most of the dermatologists we've seen for a complex case of polymigrans. We have photos of these traveling hairs, but it wasn't until we collected about 10 case histories off the internet as evidence that anyone agreed it could be a problem. No treatment was offered. What's up with this? Case histories are well documented. Where should we go? So, for those listeners that are not familiar with polymigrans, let's briefly review it before we dive into this case. So, cutaneous polymigrans is a rare phenomenon where you get fragments of hair that are embedded in the skin, and those fragments can move. And they often move in a straight or linear manner. And when this phenomenon happens, often there's a debate by practitioners as to whether this is some kind of a worm infection, especially a particular infection called cutaneous larva migrans. And cutaneous polymigrans has been reported for many years in the literature, and there's about 50 or so cases that have been reported so far. And these hairs get trapped in the skin, and they can be seen anywhere, but especially on the lower extremity, toes, sole, ankle. But they have been reported in many locations: breast, cheek, neck, abdomen. They can be asymptomatic. They can be painful. There's a wide variety of case histories. And here's a nice example from the literature to set you up for what cutaneous polymigrans is. Publication in JAD Case Reports in 2023, where the authors shared a 50-year-old man who developed cutaneous polymigrans after running a marathon. And here's the sole of his foot with this thread-like appearance, which moved in position over time. And you could see up close by trichoscopy the thread-like appearance of this hair. Another nice example in the Journal of Pediatrics of a 19-month-old girl who had cutaneous polymigrans. This was on the sole of the foot, developing after this 19-month-old girl played in the park. And here's this hair trapped in the skin. And what was noted in this 19-month-old is that when the parents were photographing this foot, this thread appearance was located in a different location 5 days before. So it had moved and it had traveled, which is typical of cutaneous polymigrans. And when the skin is scraped, because often these hairs are trapped superficially in the epidermis, these hairs can be removed, examined under the microscope to confirm that it's a hair follicle. So you can perform light microscopy to confirm that this is a hair, not a worm or not something else. You can confirm the diagnosis. So we don't know what happens. We don't know why cutaneous pilomigrans happens. It's been most commonly reported in individuals of Asian background, but it may affect a wide array of individuals. And it may be the texture of the hair, the thickness of the hair in Asian individuals, which may be a predisposing factor, but really no one knows exactly why. They often occur on the lower extremities, and it's thought that maybe walking and body motion predisposes this to develop, but really the etiology is not well understood of cutaneous pilomigrans. And the treatment is to scrape the epidermis and remove these hairs. These hairs are generally trapped superficially, not deep, but superficially. So by abrading the skin, you can create an opening where you can remove these hairs. And so when we come back to this particular case, an interesting history is given of cutaneous pilomigrans. And so in a case like this, I don't have enough information to know all the details, but generally cutaneous pilomigrans, can be diagnosed by removing that hair and examining it under light microscopy. It's uncommon for a multitude of repeat cutaneous pilomigrans lesions to be present. And so generally, after removal of the hair and confirming that it's a hair under the microscope, the issue is dealt with. Of course, one needs to control for the risk factors. If there's a lot of barefoot walking, if there's a lot of, other factors of wet work and exposure to wet, well, these may be predisposing factors, so those have to be controlled for. But it's unusual to get a multitude of repeat cutaneous pilomigrans. And sometimes when there's repeat multitude of back-to-back cases in the same patient on an ongoing basis, another diagnosis sometimes has to be considered. So in this particular case, I don't have enough information, but it should be possible to scrape the skin, remove the hair, examine it under the microscope, and confirm that it's cutaneous pilomigrans. If the hairs are difficult to remove, then certainly a larger opening can be removed, but often a simple abrasion of the skin can create an opening. But it should be possible to remove that hair. And in most cases, that stops this condition. So thank you for that very, very interesting case. And before we get to the other questions that have come in, I want to pause and thank you so much for joining me today on this webinar. And thank you for all these great questions that have come in. I figured that over a course of 2 hours, we would get to about 23, 24 questions. That's usually how many we get to each year. But do watch for other webinars that we have throughout the year. And I really enjoy this opportunity to answer some of these challenging questions. So thank you everyone for sending in such really stimulating questions. These will be posted on YouTube and our social media channels for your review at any time in the future. I do know from past sessions in our webinars that, these questions really do help a lot of people to reflect on some of these principles of hair loss, both patients and practitioners. So I really want to thank you so much for taking the time to send these in and for everyone who has joined today.